हुन्छ सर, सबैजनालाई स्वागत छ आजको प्रोग्राममा। हामीसँग आज हुनुहुन्छ डाक्टर अनन्त सुवेदी। सर, आफ्नो बारेमा केही बताइदिनुहुन्छ?
ल म भनिहाल्छु क्विकली। म ओरिजिनली चाहिँ पनौती हो मेरो घर चाहिँ, अनि मैले मेडिकल स्कुलिङ केबाट गरेँ कुम्सको, हामी फर्स्ट ब्याच। त्यसपछि कुम्समा काम सिधाएपछि मैले चाइनामा गएर पढाएँ 1 वर्ष जस्तो, म यता युएस आउनु अगाडि। अनि मैले चाहिँ रेजिडेन्सी चाहिँ बल्टिमोरबाट गरेको, त्यसपछि फेलोसिप चाहिँ एनआइएसबाट रुमेटोलोजी फेलोसिप गरेर अहिले करेन्टली चाहिँ अटेन्डिङ भएर काम गर्दैछु लास्ट 2-3 इयर्स। अनि एडिसनल मलाई अलिकति रिसर्च इन्ट्रेस्ट पनि भएको भएर मैले रिसेन्टली एमपिएस पनि कम्प्लिट गरेको छु। त्यसले गर्दा अलिकति एपिडेमियोलोजी र मोर क्रोनिक डिजिज म्यानेजमेन्टमा मेरो इन्ट्रेस्ट हो त्यो एमपिएसमा चाहिँ।
ए हजुर सर। सर, हजुरको करियर पाथवेको बारेमा अलिक बताइदिनुहुन्छ? हजुर कसरी रुमेटोलोजिस्ट हुनुभयो अथवा हजुरको मोटिभेसन के थियो त्यहाँसम्म पुग्नलाई?
मलाई खास रुमेटिडिजमा चाहिँ पहिलेदेखि नै इन्ट्रेस्ट थियो, किनभने मेरो परिवारमा चाहिँ मेरो स्पेसल्ली ग्रान्ड ममलाई पनि रुमेटोइड आर्थराइटिस थियो, मेरो 2टा आन्टीहरूलाई पनि एकदमै सिभियर रुमेटोइड आर्थराइटिस। त्यसले गर्दा मैले उहाँहरूले धेरै सफर गरेको धेरै देखेको छु कि पहिला बच्चै बेलादेखि मामा घर जाँदाखेरि सधैँ देख्थेँ उहाँहरूको जोइन्ट पेन हुने, जोइन्ट स्वेलिङ हुने, एकदम धेरै धेरै गाह्रो भएको थियो उहाँहरूलाई। अब त्यो बेलामा चाहिँ राम्रो ट्रिटमेन्ट अप्सन थिएन, त्यही भएर चाहिँ बेसिकली उहाँले ट्रिटमेन्ट पाउनु भने एनसेट्स पाएर बिचरा उहाँहरू धेरै गाह्रो भएर बित्नुभयो। इभन रुमेटोइड आर्थराइटिस रिलेटेडै भएको उहाँहरूको ऊ पनि। त्यसले गर्दा मलाई पहिल्यैदेखि एकदम इन्ट्रेस्ट थियो रुमेटोलोजीमा। अनि इन्ट्रेस्टिङली चाहिँ म अब जुन युएस आएँ, रेजिडेन्सी गरेँ, रेजिडेन्सीमा चाहिँ मैले पार्ट अफ द ट्रेनिङ मैले हपकिन्सबाट गरेको थिएँ, जन्स हपकिन्सबाट। अनि उनीहरूको एकदमै राम्रो रुमेटोलोजी ट्रेनिङ प्रोग्राम छ, त्यसमा पनि म मोर इन्फ्लुएन्स भएँ। पर्टिकुलरली मलाई रुमेटोलोजीमा इन्ट्रेस्ट भएको चाहिँ तिमीले अब सब स्पेसलिटी प्र्याक्टिस हेर्ने हो भने चाहिँ रुमेटोलोजी एउटा वान अफ द स्पेसालिटी हो जहाँ चाहिँ तिमीले चाहिँ बिरामीलाई एउटा अर्गन स्पेसिफिक भन्दा पनि मोर एज अ होल पेसेन्टको रूपमा ट्रिट गर्छौ कि, किनभने रुमेटिक डिजिजहरू मोस्ट अफ देम आर मल्टी सिस्टम डिजिज के। त्यसले गर्दा त्यो एकदम इन्ट्रेस्टिङ लाग्यो मलाई एज अ रेजिडेन्ट पहिला काम गर्दाखेरि। त्यो वान अफ द मेन रिजन चाहिँ मलाई रुमेटोलोजीमा इन्ट्रेस्ट भएको, एउटा पर्सनल आफ्नो इन्ट्रेस्ट पनि, अनि अर्को चाहिँ अलिकति प्र्याक्टिस पनि एकदम सेटिस्फाइङ खालको प्र्याक्टिस छ। त्यो हिसाबले चाहिँ पर्टिकुलरली बोथ पर्सनल टच अनि त्यसपछि प्र्याक्टिस पनि मोर सेटिस्फाइङ खालको भएको भएर चाहिँ मैले चुज गरेँ। मलाई अलिकति रिसर्चमा पनि इन्ट्रेस्ट थियो, अझ पनि छ। त्यसले गर्दा मैले अलिकति एमपिएच र एक्स्ट्रा रिसर्च पनि गरेँ जुन फेलोसिप हुँदाखेरि, अलिअलि पब्लिकेसन पनि भएको छ त्यसकै रिलेटेडमा। त्यसले गर्दा फर द फ्युचरमा अब तिम्रो कसलाई इन्ट्रेस्ट छ भने त्यसमा पनि हामी पछि कुरा गर्न सक्छौँ रिसर्चको बारेमा, बेसिक रिसर्च अथवा क्लिनिकल। प्रिडोमिनेटली मैले क्लिनिकल रिसर्च गर्ने, बेसिक साइन्स त होइन, त्यसमा फर्दर पनि म कन्ट्रिब्युट गर्न सक्छु होला इन द फ्युचर।
हजुर सर। सर, अहिले हजुर कता काम गर्नुहुन्छ?
म अहिले यो चाहिँ हस्पिटल बेस्ड प्र्याक्टिस भन्छ। यहाँ अब मेडिकल प्र्याक्टिस चाहिँ अलिकति डिफ्रेन्ट छ तिम्रो त्यहाँ नेपाल र यहाँ भन्दा चाहिँ। अब यहाँ चाहिँ कस्तो हुन्छ भने आउट पेसेन्ट प्र्याक्टिस र इन पेसेन्ट मेडिसिन इज टोटली डिफ्रेन्ट छ। एउटा डक्टर जस्तै यहाँ चाहिँ मेडिसिन नेपालमा चाहिँ अब कम्बाइन्ड मोडल छ त्यहाँ। जस्तै अब एउटा डक्टरले चाहिँ इन्टरनल मेडिसिन गर्छ भने उसले आउट पेसेन्ट प्र्याक्टिस पनि हेर्छ, इन पेसेन्ट पनि म्यानेज गर्छ। यहाँ चाहिँ बेसिकली एकदम सेपरेटेड छ। अब इनपेसेन्ट इज सेपरेट देन द आउट पेसेन्ट प्र्याक्टिस। त्यही भएर मेरो चाहिँ प्रिडोमिनेटली आउट पेसेन्ट प्र्याक्टिस हो। म अहिले करेन्टली चाहिँ नर्थ क्यारोलाइना स्टेटको नाम चाहिँ, तर राले भन्छ यो ठाउँको नाम चाहिँ। हामी वासिङटन डिसीबाट लगभग 4 आवर्स ड्राइभमा छौँ, हामी चाहिँ क्लोज टु डिसी छौँ। म चाहिँ अहिले 2 वर्ष भयो यहाँ मुभ भएको।
ए हजुर सर। सर, त्यहाँ हाम्रो हजुरको हस्पिटलमा चाहिँ कस्तो खालको केसेसहरू हजुर देख्नुहुन्छ?
इन्ट्रेस्टिङली म चाहिँ अब प्रिडोमिनेटली अडल्ट हेर्छु, पिडियाट्रिक खासै हेर्दिनँ। त्यही भएर अडल्ट रुमेटिक डिजिज भन्छौँ। म अलिकति इन्ट्रोडक्सन दिन्छु तिमीलाई पछि, रुमेटिक डिजिज भने के हेरिन्छ, कस्तो कस्तो डिजिजहरू हुन्छ। अब खास नेपालमा यहाँ चाहिँ अलिकति डिजिजको टाइप चाहिँ डिफ्रेन्ट छ, किनभने अलिकति यो पछि ब्याकग्राउन्डमा जाँदाखेरि हामी कुरा गर्छौँ मोर। यो रुमेटिक डिजिजहरूमा चाहिँ लड अफ जेनेटिक प्रिडिस्पोजनहरू छ क्या। त्यसले गर्दा चाहिँ हाम्रो जेनेटिक मेकअप ब्याक इन नेपाल र यहाँ चाहिँ जेनेटिक मेकअप डिफ्रेन्ट छ। त्यसले गर्दा अलिकति डिजिजको प्याटर्न चाहिँ डिफ्रेन्ट हुन्छ। अब प्रिडोमिनेटली मैले हेर्ने यहाँ भनेको चाहिँ मोस्ट कमन चाहिँ रुमेटोइड आर्थराइटिस हो। त्यसपछि अरू भेराइटी अफ आर्थराइटिस लाइक सोरियाटिक आर्थराइटिस, स्पन्डोलर आर्थराइटिस, त्यो चाहिँ वान अफ मोस्ट कमन भयो। अनि अरू चाहिँ अब रियरहरू हेर्दा चाहिँ लुपस पनि भेरी कमन छ यहाँ चाहिँ, लुपस भयो। अनि त्यसपछि अब मोर रियर अब भ्यास्कुलाइटिसहरू, त्यसपछि अरू खालका अटोइम्युन डिजिजहरू तिमीले सुनेको स्क्लेरोडर्मा भयो, त्योहरू मेन चाहिँ हेर्छु मैले यहाँ चाहिँ प्रिडोमिनेटली।
ए हजुर सर। सर अब हजुरको रिमेटल बारेमा केही सुरु गर्दा हुन्छ कि हाम्रो अब बेसिक्सहरु
सानो
रिमेटलको
म
बारेमा
धेरै तिमीलाई बोर गर्दिनँ मलाई खास मैले भने अगाडि यो चाहिँ मेरो आज मेन इन्ट्रेस्ट भनेको चाहिँ देयर इज अ वान स्पेशलिटी कल रुमेटोलोजी भन्ने पनि छ भन्ने खालको इन्ट्रोडक्सन मात्रै दिन खोजे हो त्यही भएर चाहिँ सकेसम्म म अलिक सजिलो तरिकाले चाहिँ इन्ट्रोडक्सन सुरु गर्छु मैले एक सानो पावर पोइन्ट पनि बनाएको छु लेट मी जस्ट सेयर है त त्यसलाई
हुन्छ सर स्योर
है त सेयर माई स्क्रिन दिजुले मलाई सेयर गर्न इनेबल गर्नुपर्छ होला त्यहाँ
I did.
है त अनि बिचमा कतै केही क्वेसनहरु छ भने मलाई सोध्दा हुन्छ रोक्दा हुन्छ अब मेरो खास आजको मेन भनेको चाहिँ निड असेसमेन्ट चाहिँ मोस्ट इम्पोर्टेन्ट कुरा हो तिमीलाई चाहिए के छ अब तिम्रो इभन प्र्याक्टिसमा अथवा करियर प्लानिङमा चाहिँ यदि रुमेटोलोजीतिर छ भने चाहिँ अब के मेरो मैले गर्न सक्ने कन्ट्रिब्युट गर्न सक्ने के छ अब तिमीहरूको अब मानौ तिमी वार्डमा जाँदाखेरि के क्वेसन आयो एउटा बिरामी देख्यो एकदम इन्ट्रेस्टिङ भयो तर एकदम डायग्नोसिस छैन त्यस्तो छ भने अब यदि केही क्वेसन छ भने त्यो पनि मलाई तिमीले इमेल गर्दा हुन्छ म इजिली अभाइलेबल छु मेरो इमेल चाहिँ पहिलो नाम दोस्रो नाम @gmail त्यो चाहिँ इजिएस्ट अप्सन हो मलाई पठाउनु लागि इनकेस चाहियो भने त्यही भएर म चाहिँ फर्स्ट अब्जेक्टिभमा चाहिँ लर्न निड असेसमेन्ट भनेर राखेको छु त्यसले गर्दा तिमीलाई मबाट हुन सक्ने हेल्पहरू इदर एकाडेमिकली करियर वाइज अथवा के छ त्यो चाहिँ मलाई इमेल गर्दा हुन्छ त्यो इमेलमा अनि म अब स्टार्टमा चाहिँ एउटा मैले आफूले देखेको अब आज भर्खर क्लिनिकमा देखेको केही बिरामीहरूको मैले सानो सिनप्सिस राखेर चाहिँ केसहरू बनाएको छ अनि त्यो केस रिलेटेड विल टक अबाउट मोर what is rheumatic disease and what are the common types of rheumatic disease. We'll talk based on the cases. And the third ma चाहिँ why we care about rheumatology, why it's important for you guys to learn about rheumatology भन्ने कुरा पनि अलिकति म बेसिक इन्ट्रोडक्सन दिन्छु त्यो अब one of the most important मा त अब तिमीलाई नै थाहा छ होला यदि कसैलाई rheumatic disease छ भने चाहिँ how difficult is to get a diagnosis and how difficult is to see a rheumatologist back in Nepal. Now I think I can count fingers like how many rheumatologists we have back in Nepal, especially outside Kathmandu. Kathmandu I think there are a couple of them. Outside Kathmandu it's extremely rare. त्यसले गर्दाखेरि चाहिँ यो चाहिँ एकदमै इम्पोर्टेन्ट स्पेशली भएको नेपालको लागि चाहिँ यदि तिमीहरुमध्ये कुनै पनि यदि फर्दर स्टडी जान लागेको छ भने अनि one good news चाहिँ रिसेन्टली पाटना हस्पिटलमा पनि रुमेटोलोजी फेलोशिप प्रोग्राम सुरु भएको छ त्यो डाक्टर बुद्धि हुनुहुन्छ उहाँको प्रोग्राम डाइरेक्टर उहाँसँग मैले पनि अलिअलि काम गराएको थिएँ पहिला त्यो प्रोग्राम सुरु गर्नको लागि त्यसले गर्दा त्यो भयो अनि अर्को चाहिँ अब रुमेटोलोजी को लागि चाहिँ बेसिक इम्युनोलोजी भेरी इम्पोर्टेन्ट छ त्यसले गर्दा म अलिकति बेसिक इन्ट्रोडक्सन सुरु गर्छु तर अब डिटेल एकदमै धेरै डिटेल छ अब आई थिंक वी निड मोर lectures down the road if you guys are more interested in immunology, so we'll go over those some of the common basic concepts in rheumatology, and then I'll just elaborate few of the common diseases that we'll be talking in the future. So I'm starting with the interesting case study clinic. So we have a 45-year-old female who presents to me with 4 months history of bilateral hand joint pain. When I examined her, she has significant swelling of her bilateral MCP joints, bilateral wrist, and she was very tender to touch and very warm to touch in those joints. I had some preliminary lab tests. In particular, ESR was very high to 40 and normally is up to 15 for her age. So now I'll open the forum. You can even speak out or you can even chat, and then you can put some of your differential diagnosis. What are you thinking this lady might have? So let me open my chat box. I'll give you 30 seconds and then we'll go over your differential diagnosis and we'll talk about what she might have. Is the chat open there? I can just go to the chat box and let's see. Chat open, right?
Yes, yeah.
30 second मा तिम्रो आफ्नो थट के छ यसो त्यहाँ राख अनि त्यसपछि म कुरा गर्छु के चाहिँ भएको छ उसको यो पर्टिकुलर पेशेन्टलाई. Chat, let me find the chat box. अब भन्दा पनि बोल्दा पनि हुन्छ अब धेरै क्राउडेड छैन जस्तो यहाँ बोल्दा पनि हुन्छ है. म च्याट ओपन गरे ल म यहाँ फलो गर्दै छु जेम ल मैले यहाँ रुमेटोइड आर्थराइटिस देखेँ RASA भनेको के भन्न खोजेको हो त्यो रिएक्टिभ आर्थराइटिस. ओके, द्याट्स अ भेरी गुड थट. Rheumatoid arthritis. Okay, so I think I'm happy that you guys have a pretty good concept, especially Binu, Nepal. So तिम्रो response I really like it. तिमीले आफ्नो thought process पनि राखेको थियो त्यो धेरै राम्रो थियो अब why this is rheumatoid arthritis. So septic arthritis. Okay, that's very good. Okay. So but this is usually when we hear about arthritis, we usually categorize them into particular term, like is it the one joint involvement, and we particularly use that monoarthritis. For this lady, she's having multiple joints, so we call this a polyarthritis. Some people use the number like more than 5 joint is polyarthritis, less than 4 or more than 2 is oligoarthritis, and then only 1 joint is monoarthritis. So for her case, I think she has polyarthritis, and one of your colleagues mentioned, Binu mentioned that it is symmetric, and that's very important. So by definition, if we call this a rheumatoid arthritis, she has to have symmetric arthritis. Now, one of the key terms that you have to pay attention in this particular case is she has signs of inflammation. And when we talk about arthritis, there is other way to categorize non-inflammatory arthritis. So that's a very key concept in arthritis. When you hear any patient, you always ask that question, is it inflammatory or is it non-inflammatory? And in inflammatory, you have a lot of other differential diagnoses within inflammatory arthritis. And in non-inflammatory, there are a couple of, not many, but a couple of them as a differential diagnosis. So based on what we hear, she has signs of inflammation as she's presenting with swelling, significant tenderness, and then warmth in her joint on our physical examination. Even with just the physical examination, you can come up with some of the differential diagnoses, and rheumatoid arthritis definitely comes in the top list of your differential diagnosis. And now your clinical thought is supplemented by some lab tests. So ESR is quite high, so that suggests or supplement your clinical impression that this is an inflammatory arthritis. So now going to the differential diagnosis of polyarticular inflammatory arthritis, so RA, rheumatoid arthritis always comes in our mind. And the few other like psoriatic arthritis will also be in the differential diagnosis. Now, reactive could also be a differential diagnosis. So we need to ask more further questions in the history to make a diagnosis of reactive arthritis. And you might also need some blood testing, further blood testing to come up with a diagnosis whether this is reactive versus rheumatoid. Now we'll talk about more about what is the role of antibodies like RA, rheumatoid factor, CCP. Those are the tests that we might need to order down the road to get to the diagnosis of rheumatoid arthritis. But based on what we hear so far, it is a polyarticular inflammatory arthritis. Now the other key concept here is the duration. Like typically RA is a chronic arthritis, meaning you have to have symptoms for more than 3 months to call this rheumatoid arthritis by definition. So this is a chronic symmetric inflammatory arthritis. And that is a typical definition. If you read at the textbook, you will see rheumatoid arthritis is a chronic symmetric inflammatory arthritis. And one key feature of rheumatoid arthritis, it particularly affects your small joints. It could be in your hand or it could be in your feet. So if we rearrange all her symptoms, she's presenting with chronic, more than 3 months, symmetric, meaning bilateral hand, inflammatory with signs of inflammation, and then arthritis, meaning she has signs of inflammation. So she has chronic symmetric inflammatory arthritis. That's a typical definition of rheumatoid arthritis. So she likely has rheumatoid arthritis. Now in clinical medicine, we don't always think of one diagnosis, right? We make a differential diagnosis. That's why we have to think of multiple things as the possibility for her symptoms. So you have to think of other possibilities. Now, to rule out those possibilities, you will do more further testing. And one of the most important is you ask for serology, like antibodies. So in her case, I will add some antibodies. I'll add rheumatoid factor. I'll add anti-citrullinated peptide or CCP. And I'll also do the X-ray because that will help us understand more about the arthritis. Particularly, we are looking for joint damage, and that is important long-term for follow-up for rheumatoid arthritis. So I'll order CCP and then rheumatoid factor. And then when I asked those tests, I got those both are positive. So that make a case that this is a seropositive, meaning she has a serology, rheumatoid factor, CCP, and then this is a seropositive rheumatoid arthritis. So likely she has rheumatoid arthritis. Now, as we discuss more, we'll talk about how we differentiate this from other form of arthritis like psoriatic arthritis. Typically, they have history of psoriasis. Most of the patients who develop psoriatic arthritis, they tend to have skin rashes, but sometimes they may not have like classic psoriasis. So it's always very important to have a very good clinical examination to find psoriasis in people like this, like who have inflammatory arthritis. So that's a quick overview of what we call inflammatory arthritis. केही क्वेसन छ यसमा म केही so far? And also comment on my speed if I'm speaking too fast. So CCP is so there are a couple of antibodies in rheumatoid arthritis. One is rheumatoid factor, or also called RF. Now there's other called anti-citrullinated peptide, or CCP, and sometimes they also call anti-CCP. So that's one of the very specific marker of rheumatoid arthritis. Yep. So that is cyclic citrullinated peptide, and this is a very important test you do if you suspect somebody have rheumatoid arthritis. And rheumatoid factor is not a specific test, but the CCP is very specific for rheumatoid arthritis. You could have positive rheumatoid factor with multiple other issues, like if somebody have infection, you could have rheumatoid factor positive, but CCP is not. So CCP is quite sensitive, or quite specific for RA. Right, let me go to the next case. Okay. So the case number 2 is also, this is a gentleman who is 85, who came to me with 1 year history of right knee pain. When I examined his joint, he has very minimal swelling, small effusion, there is no warmth, and the joint line is not tender. Now, we are comparing this gentleman with the first patient that we saw on the joint pain symptoms. So he has one joint involvement, just the right knee, and then longer history, and no particular signs of inflammation in our examination. So what are the things that you will think of in this particular gentleman? Osteoarthritis, so that is most likely, yeah. Yeah, osteoarthritis definitely comes to your mind. But what are your differential diagnoses? Now, you don't just come to one diagnosis. You have to think of differential when you think of this particular situation. So what are the other things you will think in this particular patient for the differential diagnosis? Now, it might be a little bit difficult because it's not very common. The monoarthritis, there are very few differential diagnoses for monoarthritis. So this element has a monoarthritis, that is chronic monoarthritis. Now, I'll help you guys. I think it'll be a little bit difficult for you guys to come up with more differential diagnosis. So typically when you have monoarthritis that is not inflammatory or maybe subtly inflammatory, osteoarthritis is definitely the number one. And then there's something called crystal-induced arthritis. Now, there are two basic categories of crystal-induced arthritis. One is gout. Gout is not typical, it doesn't typically present with such symptoms. Gout is more acute. But few people who have very poorly controlled gout, they could have chronic form of arthritis. And then I see the other is pseudo-gout. So pseudo-gout is a very important differential diagnosis in this particular case. And the pseudo-gout is very similar to gout, but pseudo-gout has more chronic course, like osteoarthritis. And that typically presents with one joint pain and subtle, very low level of inflammation. And the pseudo-gout is, the name suggests it sounds like gout, but the crystal is different. In the pseudo-gout, it is called CPPD crystal. In gout, you have uric acid crystals. In pseudo-gout, you have CPPD crystals. So that is calcium pyrophosphate crystals. And particularly for older age male like this, pseudo-gout is not uncommon. So it's quite a common differential diagnosis for monoarthritis. Now, the other uncommon one, we also need to think of septic arthritis. Rarely could happen, but sometimes septic arthritis could present with monoarthritis. Now, those are the common one. Rarely, sometimes rheumatoid arthritis, there is a variety of rheumatoid arthritis called palindromic rheumatism. Maybe you might have heard or not. It typically presents with very low degree of inflammation for a long period of time, just one joint. So we do think of like the palindromic rheumatism as one of the differential diagnoses for this particular gentleman. But most likely he has osteoarthritis. And from here, we'll do some blood work. I will do some inflammatory markers like ESR, CRP. I'll take a uric acid level and get an X-ray. That usually help us come up with the diagnosis. Now I'll pause if you have any questions. Otherwise, I will switch my gear to a little bit different case. This is a little bit different variety of case, but it's not uncommon in rheumatology. You will see similar cases quite often. So we have a young lady who is 23, who presents to me with 3 years history of joint pain. particularly her knees. Both the knees has been hurting for the last 3 months. When I asked further questions, she also started telling me that she also got some subtle rash in her face and then also quite a bit of fatigue for the same duration of time. And when I asked her more, she told that, oh, she was also having some chest pain that has been intermittent, non-exertional for the last 2 to 3 months. And then occasionally she gets some intermittent ulcers in her mouth. And when I examine her, she has some red erythematous rash in her bilateral malar area, and also has some inflammatory arthritis in her bilateral knees. And when I meant inflammatory arthritis, she has swelling and then warm to touch and also quite tender, and she has limited range of motion. So those are some of the subtle signs of inflammation in her knees. So now I'll start with some of the differential diagnosis. Now I see young female malar rash. This is a textbook picture of lupus. So most likely she has lupus. And you mentioned about the butterfly rash. That is one of the typical signs, but very careful before you just come up with one diagnosis. So you have to think of other things. What could be causing this multi-system symptoms? Like you are having joint pain symptoms, you are having some cardiac symptoms, you are having some skin symptoms, you are having some mucous membrane symptoms. So you have to have multi-organ involvement. So you have to think of other problem that could also cause multi-organ problems. So what could be your other differential diagnosis? And this will be a little bit challenging because if you think of multi-system disease, lupus will always be in your differential diagnosis. Now, the other thing we should also think is sometimes could cause, and psoriasis is also a good thought. So psoriasis could cause skin rash. The type of rash may be different, but sometimes you may not be able to just to tell by looking at the rash. So psoriasis, you need to think, but the oral ulcers, the chest pain is a little bit less likely with psoriasis. Sjogren's, that's a very good thought. I'm really glad that you guys have learned quite a bit of rheumatology. So the Sjogren's is definitely a very good differential diagnosis. And Sjogren's do cause inflammatory arthritis. It could cause rash. So that's a very good differential diagnosis. So we talk about lupus, we talk about psoriasis, we talk about Sjogren's, and vasculitis. I always think of vasculitis if you have someone young like her and who comes with multi-organ problem, like the skin, the joint, and then the heart. So the vasculitis, different form of vasculitis could also cause similar symptoms. But I think that's a very good list of differential diagnosis. Now, lupus is a difficult diagnosis, meaning there is not a specific test that will give you the diagnosis. So you have to think of multiple blood testing, including ANA, that is called anti-nuclear antibody. That's always a starting point in the workup for lupus. So I'll start with ANA testing. I'll also work up for some vasculitis. There are some testing that are quite specific for vasculitis. It's called ANCA antibodies. I'll also think of Sjogren's antibodies. So we'll be doing a lot of serology. Now, in rheumatology, when you become a rheumatologist, you are a lot of testing. Now, I used to make joke with my patients. So we are vampires. We take a lot of blood because we need to do a lot of testing in serology. So, but I say that we are vampires who always help you. So that's a joke I always do with my patients. So we'll be doing a lot of serology testing in this particular patient to come up with a diagnosis. Now, let me pause there if you have any questions. Now, down the road, we'll talk about a lot of the different diseases and then what are the different things that we might need to do on workup and then the treatment. So that's I think our future plan, but drug-induced. So drug-induced lupus is definitely a good thought. And in your history, you'll be asking a lot of questions on whether they have been on any new drug. So that's a good thought that it could be drug-induced lupus. Now, in rheumatology in general, history become a very important aspect on coming with a diagnosis. And then followed by your good clinical assessment, good clinical examination is very important. So if you ask a lot of questions, you might be able to pinpoint to the diagnosis very well, just based on the history and examination. So even in the US, I still rely a lot on my history and physical examination. And for you guys back in Nepal, even though you may not have all the serology, if you do a good physical exam, good history, I think many of the time you will be able to get to the diagnosis, even without any blood testing. So that is very important in rheumatology, a good exam, a good history. So now let me go to a little bit of overview on what we'll be talking down the road. So rheumatic disease, as we discussed, common one, we talk about arthritis. There could be varieties of arthritis, rheumatoid, psoriatic, Sjogren. So arthritis in general is a common disease that we see quite often. And then other group of disease we call connective tissue disease. Now we discussed 3 cases, the 2 were arthritis and the third one was lupus. So lupus is one of the common connective tissue disease. We use lupus as a very prototype form of connective tissue disease. In arthritis, as we discussed, osteoarthritis is very common. Rheumatoid, psoriatic, and spondyloarthritis are common type of arthritis that as a rheumatologist you'll be seeing in your clinic. And in the connective tissue disease, these are the 3 common ones: the systemic lupus erythematosus or SLE, the inflammatory myopathies, that is also a broader group of disease which particularly affect your muscles, also called myositis. And there's other variety called scleroderma, which is also another form of connective tissue disease. Now, this is just a quick overview of some of the common diseases. There are much more. This is just a common examples of the arthritis and connective tissue disease. And there are different ways we categorize rheumatic disease. Sometimes it becomes very complicated when we classify diseases, but this is a simple way to understand the basic concept in rheumatology. Now, how much time do you have?
We still have some.
Okay.
I think. Yeah.
So now my next topic is just to start a basic, my screen is still here, right? Let me.
Yes,
okay.
It's visible, yeah.
So this is a basic slide that give you some overview. So now the immunology is much more complicated than what I'm projecting in this picture, but this will give you some sense of what are the different cells involved, what is the basic immunology. Most of the time when you open your immunology textbook, they usually categorize immunology into adaptive immune system on your right-hand side, the orange circle, and then on your left side, you will see the innate immune system. So the innate is one branch of your immune system and the adaptive is other branch of your immune system. So this is a basic, easy way to understand immunology. Now, when you go inside the circle, there are many cells. I don't think you have to remember everything, but when you go for your boards, they might ask you these specific things, but just get a basic sense that these are the basic cells that are involved in innate immune response. And then these are the cells which are involved in adaptive immune system. Now, the common cells in adaptive are the lymphocytes. And we categorize them into 2 branches called B cells and the T cells. In the basic sense, the B cells are the one, and the B name, it came from bone marrow. So they originally are derived from bone marrow. That's why we call them B cells. And they usually mature in the B cells, and most of the time they stay in the bone marrow. That's why they are called B cells. And these are the ones that make the antibodies. Now, sometimes the antibody could be secreted in your bloodstream, or they could be hanging in the B cell surface. And we call them B cell receptors. So the B cells basic is they produce antibodies. Now the T cells is the other branch of your adaptive immune system. And the name T cells come from thymus. So they start with bone marrow, but they go and then they mature in the T cell, in thymus. That's why they are called the T cells. And until our adulthood, they stay in the thymus. And there are 2 branches of the T cells, like we call CD8 and CD4. These are the 2 type of T cells. Now we'll go in more detail on what are the function of these 2 branches. But basically T cells, they work with B cells to help make good antibodies. And they also are very good at killing pathogens. They are very good at killing particularly the viruses. And they particularly kill the cells that are infected with the virus. Like let's suppose if you have a SARS-CoV-2 infection, the T cells play a very important role in killing those cells that have the viruses. So these are what we call cell-mediated immune response. Basically, it kills the cells that are infected with the pathogen. So we talk about the B cells, T cells. Now on your left side, you will see a lot of other cells of the innate immune branch. Now you will see the macrophage that we call the first defense. So whenever you get infected, the macrophage is the first guy that goes to your cells and that try to protect you from the viruses. Even with the viral infection, they are quite helpful to start the immune response. Now there are a few other called dendritic cells. There are something called natural killer cells. There are basophils, the mast cells, the eosinophil, neutrophil. So there are all the different players in your innate immune response. Now the innate is what we call the preliminary response. They don't differentiate between viruses, bacteria. They kill everything, like every pathogen that attack your cells, they usually kill them. Compared to the adaptive, they are more specific. They particularly, one B cells particularly help kill bacteria, one particular B cells help kill viruses and the parasites. So they are very specific for a particular pathogen. Compared to innate system, they are very basic. They kill everything. They don't differentiate between viruses or bacteria. Now there is something in the middle that there is a intersection between those two cells. There is something called T cells, also called T delta cells, and there is something called natural killer cells. So they usually they belong to the both groups. Sometimes they work as the innate cells, and sometimes they also work as the adaptive immune cells. So they usually intersect with each other. Now, there is also a very good intersection between the innate response and the adaptive response. Now, we'll talk more in the more detail how they interact, but they always interact with each other to fight against any form of pathogen, either virus or the basics on innate versus the adaptive. Any question on this slide? Now, let me open my chat box if you have any. Let's see. Or you can speak up if you have any question. I'm trying to open my chat. It's hiding somewhere. Okay, I didn't see anything, so I'll go to my next slide. So this is another slide just to give a sense of where they come from.
Is it memory and killer cell are the same?
Memory or killer cell. Okay, so those are not the same. So the memory, this is a part of a B cell. So the memory, the name itself suggests what they do is they memorize the pathogen. Now, a good example is when you get vaccinated. When you get vaccine, your body is exposed to an antigen. Like if you get a COVID-19 vaccine, what happens is there's a COVID-19 virus antigen that is attached with the vaccine. And your B cells, it recognizes that, oh, this is a virus that I need to make antibodies. So your B cells make antibodies. Now the antibodies has they have a lifespan. So they usually stay in your system for a couple of months and they usually are excreted out. So they are proteins, so they are degraded. Now, if you get reinfected with another episode of the COVID-19, what the B cells does is there is a group of B cells called memory B cells, which usually remembers those antigens. And then when you get infected, they remember that, oh, this is the COVID-19 virus, so I have to make these antibodies. So they remember those antigens and make antibodies immediately. Within few days, within few hours, they make antibodies. And then that is how the vaccine works. So there are a variety of, the memory B cells are a variety of B cells that usually recognize the antigen after they are exposed to a particular antigen. And this is a very good example of how vaccine works by stimulating the memory B cells. And they are different than the killer cells. So the killer cells, there are something called T cells, and there is something called CD8 positive T cells that are particularly known as the killer cells. And then the name, the killer, they usually kill cells which are infected by viruses. And the killer cells are predominantly the T cells. Okay. Now I'll make you guys dizzy with this next slide. I'm alerting you because this is a very complicated slide. And then the reason I put this complicated slide is just to give you a sense of how complicated is immunology. Now let me project a little bit better. And this I just got from a review that they reviewed about immunopathology in COVID-19. And they are talking about how COVID-19 disrupt your immune system and how medications that are used to treat COVID-19 could help patients get out of the problem. So this just gives you a sense of how complicated is the disease. Now, I don't want you to go through everything here, but basically what it's showing that when the, now I'm highlighting some of the things. So this is a COVID-19 virus that attack your body, particularly the lung. Now in the lung, there is a lot of immune cells that are coming here. And that is one of the problems what happens in most of the patients with COVID-19 who are sick. There is a lot of inflammation that is happening in your lungs or alveoli. And that lead to hypoxia. They get respiratory failure. They need intubation because there is a lot of inflammation in the lungs. Now, you might have heard of treatment for COVID-19. One of the treatment they use is dexamethasone. That is one of the steroid. And how it helps is it helps calm down the inflammation in your lungs or any other areas because there is significant inflammation going on in your body. So the dexamethasone, one of the steroid, is it suppresses the immune system. And there is other medication that you might have also heard is called tocilizumab. So you might have heard. Now, if you look back a little more detail, there are cytokines they'll be talking. Let me find where they are talking about cytokines. Sorry, let me try to go back. Okay, so let me see what is the cytokine. There is one cytokine called IL-6, or also called interleukin-6. So if you see in the bottom part, it's called cytokine storm, right? Now you will see IL-6. So the IL-6 is one of the key cytokine that is involved in what we call cytokine storm, meaning your immune system is very hyperactive and causing a lot of damage in your cells, damage in your lungs, damage in your heart and the kidneys. So by using this cytokine, by blocking the cytokine called IL-6 by tocilizumab, that is one of the medication we use for treatment of COVID-19, that blocks the immune system and it decreases the inflammation. And that is how it helps control the inflammation. Now, there are other immune medication, like there is something called JAK inhibitors, also called Geljan, that is also used for COVID-19 infection treatment, and that also target one of the cytokines. So there are multiple pathways where we use to treat COVID-19 by controlling the inflammation that is caused by virus. Most of the time, the virus usually doesn't cause a lot of damage. That most of the damage that is done by COVID-19 infection is by our immune system. That is just dysregulated and then that is just hyperactive. And what is it trying to do is trying to heal, but it gets confused and it cannot shut down. That is what is happening. That leads to eventually to a lot of problems with COVID-19. Now I'll stop there. If you have any question, and then I will open my chat box. Oh, sure. Now, I got another question. COVID-19 affected patients with vasculitis and arthritis. Now, and was there any change in their initial management after the disease? So this is a very good question, and I get this question every day. So let me start with the vasculitis. So the vasculitis, there are various forms of vasculitis, and there are different treatment the patient is on. So it depends on what treatment you are on. Now, the treatment that we use for vasculitis, they are immunosuppression, meaning they suppress your immune system. So sometimes if that's the case, sometimes people could get more sick with the COVID-19. So that's why we have to be careful on what medication the patient is on, whether we need to stop the medication if they get COVID-19, whether to continue. So there's a lot of details involved, whether if you have a vasculitis and if you get infected. And same is for arthritis. So it depends on what medication you are on for the arthritis. Let's suppose if you are on Plaquenil or hydroxychloroquine, that is one of the medication that is used for rheumatoid arthritis, we don't typically stop it. We can continue. And the reason is it's not an immunosuppressive. It even could help with the COVID-19. Now, even they have tried in the beginning, but the clinical trial didn't show the benefit, but they have used to treat COVID-19. So that's why the specific is, we have to understand what medication you are on for the vasculitis or the arthritis. And depending on that, we will change what type of treatment change we need to do if you get COVID-19. Now, the next question is vaccine safe for such patient? And the short answer is yes. Most of the vaccine that have been approved, either the mRNA-based vaccine, there are two in the US that is called Pfizer and the Moderna, both are safe for the COVID, for patients who have autoimmune disease. And most of the other vaccines that have been approved by WHO, most of them are adenovirus vector-based vaccine and they are safe in autoimmune disease. Yeah.
So what is the, let's say, the risk of developing autoimmune infections after COVID-19?
So there has been a lot of cases with patients who get COVID-19, they recover from most of the symptoms, the acute symptoms, and they go on to have a lot of other chronic symptoms. The common one is fatigue. Chronic fatigue has become one of the main problems with COVID-19 patients who go on to continue to develop those symptoms. Some patients who also come with arthralgia. I have seen a couple of them, not many, maybe 5 in the last 6 months, who come with arthralgia, what we call, not a lot of inflammation, but just pain. We are still trying to understand, is it just the pain they have, or it is the autoimmune disease they are developing? It's still in the research area, but some patients have developed autoimmune conditions after they recover. And the most likely explanation is, as I showed you a slide earlier with the COVID-19, what it does, it just dysregulates your immune system. Now, the immune system is in a very fine balance, what we call homeostasis, meaning you have to have some degree of inflammation to protect you from infection. And then after the infection is controlled, your body knows that, oh, I need to shut it down. So the immune system usually shut it down and it doesn't cause more problem. For some people who are genetically predisposed, they tend to have a more chronic course and they continue to have some autoimmune condition like arthritis or vasculitis or like fatigue. So that is the most likely explanation, but we are still in the early phase to call this, oh, the COVID-19 is causing autoimmune condition. Yeah, I think the next question is the same. Does long COVID induce the immunogenicity for longer duration? It's likely, but I think scientifically speaking, we have not enough data to support that people who have long COVID infection, they will have autoimmune condition. It's still, I think, in the research phase.
So, yeah. So as a medical student, what can we do when we see the patients? Let's say, how can we screen them? How can we, if in some way we can diagnose them?
Excellent. So that's a very good question. I think what I'm doing is I'm planning to, let me put a slide. I'll build a slide on how we do the workup. Now, as I mentioned earlier, I think this is a very big topic. I will definitely go over in more detail, I think in the subsequent lectures on how to do workup for autoimmune condition. But the basic is, I think I will always highlight history is very important. Now, in particular, you should be spending a lot of time with your patient in your review of system. Now, in review system, what you do is you go over from head to toe. You ask all of the symptoms from head to toe, from headache, neck pain, neck stiffness, to your like any rash. So you will do if you do a very thorough review of system, I think most of the time you will be able to pick up most of the symptoms of autoimmune condition. Now, that's always a very important step, is spending enough time with the patient, asking all of the important review of system. And then the next step always become a very good examination. And then we always don't do a very good job doing examination because of multiple reasons, like you don't have enough time, you don't know what you're looking. So it's always very important to do a good physical examination. And then in Nepal, I have like, when I practice, I did the same thing. We don't do a good physical examination. We don't even have patient like put a gown, right? Do you, like when you see you're attending, examining a patient, do you remember anybody asking patient to take off their clothes and put them a gown? Like, do you remember anybody? I don't think I do remember. Like when I was in the training, I never had anybody who take off their clothes to examine. So that's why I think you should learn that practice. Now, I'm so glad that I'm talking with you guys because you are our next generation of our doctors. So if you start doing that, I think it will become a practice. And when you become attending, you will teach your medical student the same thing. So I think that's a very important. Most of the time, if you examine your patient, you will come up with a diagnosis, even without ordering any blood test. So that's why the exam, the history is absolutely, I think those are the keys. Now the test, we'll talk more. There are blood testing that I'll help you guys. What are the tests you need? And the other key is we don't do a blanket testing everything, right? You cannot do all the testing, right? That's why you have to have a differential diagnosis before even you order a blood test, so that you can order the right test to find out the right differential diagnosis or right treatment. Is there possibility of developing autoimmune disease after certain period of recovering from COVID-19? Usually it's not. Usually it happens is they recover from most of the symptoms, it continues. I haven't seen people who recover everything, got better, and then later on develop other autoimmune disease. But sometimes it could, it's a possibility, but I haven't seen yet that people have recovered from COVID-19 and later on they develop other autoimmune diseases.
I saw, and let's say we will be working some 2 years or 3 years in rural settings after our MBBS and all. So
Yeah.
I was so there was this one thing, like while working in rural settings where we don't have proper resources and all that. So what can be our ways of managing the patients there? Do we immediately need to refer them, or some way we can manage them
I
in
think one
community
of the
setting?
key when you see any patient is how sick is the patient. I think that is always, you always ask that question. How sick is the patient? Is the patient like need to immediately go to the ER, or do I need to immediately admit the patient? So that is always, that's called triaging, right? Any disease, now not autoimmune disease, but any disease, when you see somebody in the OPD or in the ER, you always triage. So that is the same principle for rheumatology. You triage based on how severe is your disease and what are the diseases you are thinking as the likely differential diagnosis. Now, let's suppose if you think somebody have vasculitis, you have to be very, you have to think is that an urgent disease, because vasculitis causes a lot of damage very fast. Within a couple of days, the patient could have a lot of issues, like including renal failure, including respiratory failure. So it's a very severe disease. So you don't have a lot of time to think about if you think this is vasculitis based on your clinical assessment. If you think vasculitis, definitely, I think I will ask them send to a better center where they can do everything together quickly. But if you think somebody have rheumatoid arthritis, somebody have osteoarthritis, I think you have time to think about. You have some time to think about doing some blood testing. You have some time to have a follow-up. You don't need to make a diagnosis on the same visit, right? You can tell the patient, be honest, like, oh, this is what I'm thinking, this is what I'm doing to find the cause. So try to explain the patient so that they will not be as anxious. Now, one thing also in medicine, in Nepal practice, we are not very honest enough with our patients. So we are still trying to, I think medical ethics is still evolving in Nepal. So that is one area where we still have a lot of room for development, right? We don't talk about ethics. We don't talk about what's the patient right, what's the doctor right. So I think that is one thing that we have to, now you are a young generation, so hopefully that you are learning more. That's why always be honest with your patient. Like, this is what I'm thinking. This is not a severe disease that will kill you in the next couple of days. So this is what I'm doing. This is how I'm helping. So try to help them with symptoms and continue to follow them, like see them back in a month or two, and then continue to follow how they are doing. And then the disease will usually declare itself, like if you are not sure what is the disease. So the triage is always very important.
Okay, sir. So do the patients need any kind of dietary modifications after they've been diagnosed?
What they need?
Any dietary modifications?
Diet in rheumatology, I don't think there is a lot of scientific basis on dietary changes, particularly like rheumatoid arthritis, lupus. Now, there's a concept called microbiome. I'm not sure how much you guys have heard of the microbiome. Have you guys heard of microbiome?
Just odd.
Yeah, so this concept that is coming up is the microbiome is just a collection of normal common cells or bacteria in your colon. Now, especially in mouse studies, there have been studies showing that people who have autoimmune disease, they have a certain type of microbiome, meaning they have a particular type of bacteria in your colon. And that predisposes you to have certain autoimmune disease like rheumatoid arthritis, lupus, or psoriasis or psoriatic arthritis. So there is research, good research based on mouse model that the microbiome do change your susceptibility to have autoimmune disease. Now the microbiome depends on what you eat. So a lot of the microbiome is changed by your diet. So there is an indirect role that diet affect your microbiome and microbiome affect your chances or risk of autoimmune disease. So there is an indirect evidence that there is a role of diet, but the direct evidence, we don't have a lot of data to support. Now in Nepal, our diet is very good compared to what we have here in the US. The diet is very good. And that might be one of the reasons that the incidence of autoimmune disease is not as common in Nepal than in the US because of the diet that we have there. We have a better diet. We eat more organic. We eat most of the thing that is grown in our home garden. So that's why we are definitely healthier than in the US if we look at the autoimmune disease incidence.
Well, thank you, sir, for providing your valuable time and your insights on rheumatology. And thank you all, everyone, for joining this session. Thank you.
Okay, so definitely, I think we have a lot of agendas to cover down the road. So let's make a plan now based on what you guys are available. I'm open. Now, other thing, I'm also working with some of my colleagues back home in Nepal is starting a telemedicine service that I can work from here and help you guide, just do a video consult or telemedicine consult. Now, I had started a lot of things back March in 2019, but COVID shattered everything. So everything changed. So unfortunately, we have not been able to keep in touch, but hopefully things will get better and hopefully you guys are also safe. And then down the road, that is something I definitely is looking forward to work you guys. Now, definitely in the next year or two, you will be attending. So definitely I'm looking forward to work in collaboration with you guys. And
that's when your expertise comes in handy, when Dipesh goes to a rural setting and he has this case and he just shoots the email or sends you
or email me, and then I can even see a patient like with you. Now these days technology has enabled us to connect from anywhere, right? So that's why we should plan something in the future that this will be another thing that we can continue to work on.
Yes, and we will be doing a series on rheumatology, and I think Dr. Subedi is going to make each of you expert in some level.
I'm hoping. Even though I'm not here, I'm trying to have you guys be my eyes and my hand.
Excellent, and we really appreciate you giving us time and energy and your effort in educating us. Thank you, Dr. Subedi.
Okay.